Good morning, everybody. I'm Adam Orty and I work in the NHS team here at Qlik, and I'd like to introduce you to some of your peers, Chris Green and Richard Ewins, who kindly joined us today from East Kent University Hospital and will be presenting the Beautiful Data webinar. What I just need to do now is to read a little bit of the legal disclaimer. This presentation contains forward-looking statements, including but not limited to statements regarding the value and effectiveness of QlikTech's products and QlikTech's growth, expansion and market leadership that involves risks, uncertainties, assumptions and other factors which, if they do not materialise or prove correct, could cause QlikTech's results to differ materially from those expressed or implied by such forward-looking statements. So now we've got the formality of the legal disclaimer over, I just want to run you through what we're going to do today. So with the agenda, I'll be doing a little bit of an introduction about Qlik and the NHS. Then it will be over to Chris and Richard, who will be talking about East Kent and their story so far, and then we'll wrap it up and take any sort of questions that you may have. So if you look on the right-hand side of your screen, you're able to provide questions that we can answer, and we'll try to do as many as possible, but for those that we can't answer today, we'll be able to get somebody to look at them, whether it's from a technical point of view or whether it just needs a little bit more of Rich and Chris's time, and we'll be able to answer it in a more thorough fashion. So today Chris and Richard will be giving you an in-depth view of their interesting work that they've been doing at East Kent through the Beautiful Data initiative, and how they've been able to transform the way that information is used, consumed and acted upon at their trust using QlikView as the platform to deliver this change. Now, Qlik's business intelligence platform is used in over 160 trusts, and we've been improving visibility and performance across a broad cross-section of areas, including finance, where it's heavily utilised for patient-level costing and service line reporting, through to operation and clinical performance, where it's used to improve referral to treatment time, A&E, theatre optimisation and many other key areas. So we've probably got about a dozen trusts so far that are using it trust-wide, and we are starting to see more and more deployments being utilised within the CCGs and the CSUs. So as you'll see from today's presentation, QlikView is a very versatile and easy to use tool which will help you to unlock your data, gain a better picture of your care pathway and deliver improvements for employees and patients across your respective organisations. So just to let you know, this presentation is being recorded, so if you do have to step out or you'd like to circulate it amongst your colleagues, feel free to do so, and we'll be sending you a link with that at the end of this webinar. So without further ado, I'd like to pass over to Chris and Richard so that they can tell you all about Beautiful Data.
Thanks, Adam. And I hope everyone can hear me nice and clearly. I'm sure I'll be told if not. So what we're just going to do is just basically going to take you through a brief presentation and talk about how we implemented Qlik down at East Kent, and also show you some of the products that we've developed as well. And hopefully, if you've got any questions, whether it's regarding implementation or of a technical nature, please feel free to type them in the question box, as Adam said. So I'm just going to move this on. A shameless plug there to follow us on Twitter. Please feel free to make any comments as we go along at EK Beautiful Info. So just to give you a bit of a historic state around East Kent Hospital, so we're kind of a fairly large organisation. We serve a population of about 750,000 people down in East Kent. We've got 3 large district general hospitals. We've got a bed base of around 1,200 beds. And I joined about 5 years ago, and it was kind of it was a state of flux, really. We had a relatively small information department of about 6 people, and it was basically firefighting. There was no intuitive or predictive work going on. It was sending out multiple Excel spreadsheets, and basically there was nobody who had like a central function around if somebody had a specific question around A&E or 18 weeks or cancer reporting. A request just came into the information department, and whoever was free picked that up, and it worked to a point. So you could kind of argue that, you know, if it's not broken, then why would you go about fixing it? But what we did was, around 2 years ago, was we kind of, the information department as a whole, decided that we needed an information strategy for the trust. Serving such a large population of about 7,000 employees, one of our biggest challenges was the amount of requests that we were actually getting for information. And there was a lot of movement away from anecdotal evidence to actually factual-based evidence, particularly around business cases. When a business case is written to go to the finance director, anecdote evidence doesn't really cut much mustard with them. They actually need to know, if I do X, then I'm going to get Y out of it. So a real good return on investment. So we actually spent a lot of time creating an information strategy, which took quite a long period of time, but it was basically built on 4 pillars. And they're written on screen: transparent, timely, triangulated, and trusted. Now, transparent, the obvious way to explain this one is particularly around the consultant revalidation process, which is happening at the moment. And basically what we said to everybody, all of our consultants, was that we're going to publish data on you whether you like it or not. We kind of phrased it a little bit different to that, but that was in effect what we were doing. And what we wanted was, we wanted them to engage with us, because we could put up their, we could publish their crude mortality rates, their HSMR figure, so on and so forth. But if they didn't believe it, then it'd be really difficult to engage with them. So we chose some particularly prickly consultants that we knew they might kick up a bit of a fuss. And what we did was actually had quite a long period of engagement with these people to make sure that they understood what it was that we were publishing. Timely was a real big thing for us, because when people make decisions, they're making them predominantly based on stuff that is happening now. It's rare that they kind of would have a look at what's happened over the 3 years ago and make decisions upon that. And one of the areas that I look after in my day-to-day role is A&E. And obviously that's a continually moving beast, and I'll come on to talk more about that and the reports we've developed a little bit later on. But actually, what's the point in even having a look at what happened in A&E yesterday or the day before or the weekend or last week? What you actually want to know is you want to be able to know what's happening right now. And particularly for us down at East Kent, we've got 3 sites, as I said, and each one of those is about 35 miles apart. And our general managers and our executive team cannot be on each site at the same time. And so what we created was a report, which I'll show you a little bit later. It's a very, very simple report which has all of our emergency departments and the state of play in each of those, so people can make real-time decisions. A real key around this, though, is that things will be triangulated. And like I was talking about with the consultant evidence, actually having crude mortality rates, you have to be able to compare that with HSMR, SHIMI, RAMI, other areas, because then people understand it. And then coming on to the 4th point, because we've gone through the whole process of it being transparent, people know that we're going to publish it, being timely, that people can access it wherever and whenever they want to, and being triangulated with other national-based evidence, people understand it and they will trust it. And we make quite a big effort. You'll see in the bottom right-hand corner, we've got the EKBI logo on this. Now, we make a big effort around when we publish a report, we will put this logo on it as almost like a kite mark, as our seal of approval, that has gone through the correct channels in order to get data clarification, in order to access different guidance that we need to, whether it's coming from 18-week, whether it's coming from national guidance, or whether it's something that we've come up with ourselves as well. We also came up with a concept in the information strategy, which is a bit of a hashtag that we have on Twitter called Data into Action. And there is a big thing at the moment around big data, and I'll come on to talk about that in a couple of slides' time. And I do have a massive problem with the phrase big data, but which I kind of will touch on just briefly. But basically, data is just a number. Data is good, but it's actually what you do with it, which is really important. So if we take, for example, that what's the number of A&E attendances that we had yesterday? Well, okay, so that's 604. Okay, that's a piece of data. Moving on to information is, okay, and so that is higher than our predicted levels. So that's good, that's taking it on one stage further. The next stage is putting into knowledge. Okay, so it was higher than our expected levels. Why was it? Okay, so it was coming from our being driven by the number of ambulances that came to us from out of area, for example. And that's moving more onto the knowledge base. But then the real big win is when we move over to action. So if we know that it's been, we've got 604 A&E attendances, we know that that's higher than expected, we know that it's been driven by our ambulances, we know that we can go and speak to our ambulance trust to find out why that's happened and whether that's going to continue in the future, so that we can make real-time decisions upon our resources within our A&E departments. And then if we think that it's going to continue, what the impact could be for our admissions. What we wanted to create was the next stage, which is basically how do you stop people trying to find information, which I know sounds a bit converse from what I've just been talking about, but actually you don't want people who are clinicians or operational people having to look for information. If something is of significance, what you want to be able to do is you have to be able to send out a push alert to those people to say, right, okay, this is what you should be looking for and this is what you should be doing. So what you'll see over here is the presentation. Now, a lot of this is, and we do say beautiful information, which is a kind of a little bit tongue-in-cheek, but if you make something visually appealing, people tend to look at it more. So what you'll see here is our live A&E screen, and so this is what it looks like on an iPad using the Qlik app, which has been a fantastic improvement for us in being able to publish information very, very quickly. And I'll come on to show you more about that. But what actually we've got on there is that we've worked on the presentation aspect. Rich and his team have done a fantastic job in publishing information really, really nicely. Then we're working more on prediction. So can we work out how many patients are going to turn up at A&E today, over the next hour, over the weekends, and so on and so forth. But then actually, if we think that because of the way in which we presented something, the way in which we predicted it, if we should then send a push alert out to our A&E staff to say, we think you're going to have a big rush of A&E attendances over the next 6 hours, then basically we're not asking people to go and look for information, we're sending them a text alert to say, you should be aware of this. And that's been a real big thing for us, and it's something that Rich and I are continuing to work on for both A&E and other areas as well. We're doing a lot of collaborative work as well, and there'll be some people, some organisations on here that you'll be aware of, and some which you may not be. But it's really important to understand that it's rare that one person would have the answers to everything. I'd like to say that that was us, but I would be lying if that was. And so what we've done is we've aligned ourselves with organisations which we can learn from. So obviously, you know, the whole reason why we went down the Qlik route was that one of our main aims in our information strategy, and talking about the 4 pillars we've got, is being transparent and timely, and that we had no way of publishing things on the web. And so we wanted to have a product that we could easily upload information to, a product of some description, and be able to direct people to so they can get it wherever and whenever they wanted to. The real key thing is for us is that when we've been at some of the NHS IMAS events, there was one a few weeks ago up in Birmingham, and I was up there with one of our executive directors, and we were able to be up in Birmingham but dial in via our secure network using the Qlik app and have a look at the state of our hospitals. Now, I'm nowhere near our hospitals, but I could make real-time decisions anywhere and at any time based upon the information we publish in. We're also working with people like Monitor and Cerner, and there's loads of different organisations that we're working with. The NIHR is a really interesting one because of the Qlik product that we've got regarding our current inpatients. We're actually working with them to push alert if a patient is suitable for a clinical trial. And that's something that's not been done in any other healthcare organisation in the country, so that's something we're working on with them. So this is one of the first products that was developed by Rich. It's our balanced scorecard. Now, immediately you might kind of look at that and think, well, okay, it's information, but I don't think it's particularly beautiful. But actually, what this did is, this is our corporate performance report. So every trust in the country will have one of those. And this one page report actually replaced a 180-page paper report, which was printed and sent out to all of our executive teams and our non-executive directors. And the innovative thing here is that it's got multiple feeds from multiple different systems. So you've got patient safety metrics over here, such as MRSA rates, C. difficile rates. You've got effectiveness, looking at our A&E metrics, our sequin targets, so on and so forth, patient experience, finance, HR. And so what you've got is you've got information being fed in from our PAS system on the patient side, but then you've also got things being fed in from feeder sheets, you've got things being fed in from our finance teams and access and productivity. And this was one of the biggest barriers, was that we found it very simple to get information from our PAS system, because that's something we've been doing for years. But actually getting data from multiple systems was a new challenge, and something which Rich and his team have worked incredibly hard on, and are now getting more and more information on a daily basis. This was one of the first live products. Now, we Uncoded Spells was a big problem for East Kent around about 18 months, 2 years ago, and we were losing approximately £1 to £1.5 million a year on Uncoded Spells, and I imagine that's not dissimilar from many other trusts around the country. And what we wanted to do was we wanted to be able to have a product that anybody could have a look at wherever and whenever they wanted to, regarding to how many days we had to code a particular number of spells. So, for example, if this was this month, we had 18 days to the freeze date. Up here, it would tell you some simple information. So the number of uncoded spells, and that was 218. And we put an estimated value around that. So the estimated uncoded value at the moment is £250,000. So unsurprisingly, our finance director was very, very exercised about this. And what you can now see is what proportion is going to what specialty and at what site they are. And although I can't do it on the PowerPoint presentation, on the report I can simply click on the dial and I can drill down to surgery and I can find out what ward the notes are on. And so what we have is we have all of our runners in our coding department with an iPad on their trolleys, and they know exactly where the notes are. And we see a dramatic reduction in the number of uncoded spells that we have and the amount of income that we've generated for those spells. And so actually, with the outlay of buying a Qlik product, just in this one product alone, it's almost paid for itself. We've also done a lot of bespoke development. So yes, we've done very high-level corporate performance reports and uncoded spells, for example, but we're the lead for Kent and Medway for certain things such as acute kidney injury, PPCI, and these people have come to us with specific requests, very, very detailed analysis. And so we've been able to put the development team's expertise into this to kind of say, okay, we can do a report. We've also done additional dashboards for other aspects of the organisation. And we've almost become a product of our own success through the organisation, which has been a good thing and also a challenge for Rich and his team, because there's only 3 or 4 people in the team, and actually more and more people have come to that, come to the conclusion that actually why should they do an Excel-based report that people have always picked up on, and actually why don't we just put it into QlikView so that people can access it wherever and whenever they want to. We do a lot of geographic mapping down at East Kent. We cover, 750,000 population. It actually covers quite a large square mileage as well. So what we do a lot of is we work out where the patients are coming to and where they're going to in order to receive their treatment. And a specific example around that is our DNA rates for our outpatient appointments. Now, some of this stuff isn't rocket science, but in actually put it on a map, people can make informed decisions very, very quickly and make it very visual. So although we were talking about in meetings that the further away a patient travels, the higher the DNA rate, people couldn't quite really understand what that kind of meant. And so we just simply put that on a map and showed that, for example, for our respiratory service, the further the patient travels, the higher the DNA rate. And what we were then able to do, because it was very visual, we were able to just copy and paste that simply into a business case and say, actually, we want to be able to run a satellite clinic in the north of the region, and we cut down our DNA rates and improve our efficiency. Very nice, very simple information, but people can make decisions very quickly on it. And so just moving on to big data, the interesting thing is that everyone talks about big data now, and it's almost turned into a game of top trumps for the data scientists around. I was looking at something on Twitter yesterday around the US government and petabytes and terabytes and all these different types of bytes. And actually, I want to come back to the point we talked about earlier, which is big data, so what? And I'll just give you the example that for one of our reports, it's built up in kind of this way, and I've kind of just picked out the larger elements. So we've got loads of historic data, and that table's got circa 2.3 million rows of data in it. We've then got our current data tables, which has got roughly around 250,000 tables. And then we've got some lookup data tables, which for the geeks amongst you will certainly know all about those, and so all the codes and how they link up to names of specialties or doctors or sites or example. And we've got roughly 26 of those lookup tables, and each one of those has just got around 15 variables in. And then we've got demographic information, so we've got 3 of those tables, and they've got 1.4 million rows. So the big challenge for us was actually about how do you take this many rows of data and how do you make it visually appealing. And so that's the goal, and so how do we use data to get there? So I'm going to come on to explain and show you what that report looks like in a couple of minutes. So what's next for eKPI? Well, we've got a lot more predictive work. Richard and I are just working on, as I briefly explained earlier, is about a forecasting tool for A&E. So I know exactly how many patients are in our A&E departments right now, but actually, if I have 35 patients in the department at 11 o'clock in the morning, what does that actually mean? Does that mean that it's going to fall over? Does it not? How many patients are going to be admitted? How many patients are going to go home? How many patients are going to go here? So actually the predictive work and then be able to inform operational and executive teams around what is going to happen in A&E is a real massive thing for us. And that kind of leads into the statistical modelling. We're working with a lot of our external health economy partners to look at capacity planning. And that's a real big thing for us at the moment because you know, the patients are not necessarily best suited to stay in hospital, but if they should be moved into a social services environment or a community hospitals environment, how do we get that patient to the most appropriate place of care as soon as possible? And how do we know how many beds are we going to need in those areas? So we're working with local health economy partners, both social service community hospitals, but also the Academic Health Science Network in in Sussex, and the Quality Observatory to triangulate some of this information. We're going to be doing a lot more push alerting. At the moment, it only relates to acute kidney injury, PPCI and A&E, but we're going to be doing a lot more around this, particularly as we build up our 18-week product range as well. A lot more collaborative working, not only with Qlik, but with other trusts around the country as well, because like I say, it's rare that one organisation will have absolutely everything cracked. And actually, when we've been going out with Qlik and with other organisations as well, is that actually we kind of learn from each other. And so actually building up a network of individuals and groups of people that we can kind of go out and bounce ideas around is really interesting and something that we would look on to do in the future. And we also want to do something as well called the Beautiful Information Factory. Over the past year, we've kind of come into contact with quite a few health tech startup companies, and they've got some really interesting products and ideas that they want to do. But the difficulty they have is that they are private individuals, and they don't understand, or many of them don't understand, what the impact could be on the NHS. And so what we've started to do is we've started to invite those companies into East Kent hospitals and actually give them access to consultants, clinicians, the services, to understand how their apps can help with the local population of East Kent, and then hopefully taking it out to the wider healthcare sector. So I'm just going to move on to the product range now. Has anyone got any questions? Okay, I will move on. I think there's one question on the text, so I'll come back to that later. So this is our Trust Activity Report. You might well recognise this. It's kind of stolen from the underground map. But you know, getting back to the whole point about something being visually appealing, is we wanted people to have an understanding of how patients can come into our hospitals. And each one of the lines is a different way in which patients can come into the hospital. So for example, you've got this line over here and coming into the outpatient route, being primary care or non-primary care referrals. And each one of these has also got a dot. And the dot shows you whether it's above or below our contracted activity. So very nice and very visual. Anybody in the organisation, whether it's an analyst or a service manager or executive team member, can come in and say, right, okay, primary care referrals are above plan. And I can immediately click on a dot and it would pull up a report, and I can focus on just on primary care referrals. Or I could do it for ward attenders or A&E attendances or any of the areas that you see here. You can click into and it opens up another page on our report. So if I was to come in and kind of say, okay, I'm quite interested in primary care referrals, I click on that dot and it pulls me up a very nice run chart of the primary care referrals over the past 4 years. What you'll notice here is that the whole page is taken up with a graph. And that's really, really important for us, is that we've seen quite a few different Qlik products, and that half of the page is taken up with a graph and half of the page is taken up with selection criteria. And I'll come on to show you how we do that later. What you can also do is you can also change it between a graph and a table, just using the simple toggle buttons over here. You can transfer SPC being on or off, depending upon whether people know what SPC stands for. And you can change the type of graph that you want as well, so that if you want to have a look at a cumulative report against last year, you can click on that. If you want to just have a look at what the month is, you can just click on that. It's very, very intuitive, very easy to use. And so what we can do is, in order to change our selection criteria, so at the moment I've only selected non-elective, but all I have to do is click on the selection criteria bar over here, and it comes along, takes up the whole page, and you can change it by year, or by consultant, or by specialty, or by point of delivery, or by loads and loads of different various connotations that you so choose to. As I was talking about with the geographical mapping software we've done, this is all using the some open source data that we've got off the web. And what somebody came to us to talk to us about is actually that we've got 3 large hospitals. We've got the William Harvey in Ashford, we've got Kent and Canterbury in Canterbury, and we've got the QEQM over in Margate. And we've got members of staff who live all over the South East region, so some going up to South East London. And what basically somebody came up to us with was a question around, okay, so if we move some of the back office functions away from the hospital and we put them in one particular location, where should we put them? And obviously it's something very difficult to look at in an Excel spreadsheet, or if somebody would just come up with an idea. But actually doing something very visual enabled us to come up with something really quite simple. So what they're able to do is they're able to click, okay, so I'm going to select a particular site, or I'm going to select a particular pay scale or distribution or position title, and it changes the graph. So what the team member was able to do was able to just use this report for a couple of hours, play about with different scenarios, and make suggestions based on this. So something that historically might have taken a couple of weeks, maybe even a couple of months, they're able to make decisions on, strategic decisions, within a couple of hours. So this is the live A&E report which has been developed. So we've got 4 emergency departments. We've got a minor injuries unit in Buckland Hospital down in Dover. We've got an emergency care centre at Canterbury, and we've got 2 full A&E departments in Margate and in Ashford. I'll just give you a brief overview of these metrics for those who don't know. So you've got 3 main metrics in A&E. You've got the time to initial assessment for the ambulance patients. You've got the time to treatment being the 60 minutes to being seen by a clinical decision maker. And then you've got the 4-hour standard that everybody should be familiar with. I've taken this on a great day, so we're pretty much all green on this. So basically, once again, you've got a very, very visual representation of each of the sites and how well they're doing from midnight last night to that minute. This refreshes every 2 minutes, and so it's very, very live information. What we've also got is we've got a histogram of patients currently in the department. So we've got, for the hospital over in Margate, we've got 11 patients in between 0 and 1 hours, 6 patients between 1 and 2, 4 between 2 and 3, 3 and 4, and so on and so forth. And we have a rule at EKBI is that you should be able to get access to the information you need within 3 clicks. So, for example, if I was quite interested, my eyes are immediately drawn to, there's one patient over at Kent and Canterbury that's in over 4 hours, and so I could just double click on that 4 hours and it would take me down to that patient level information, and it would show me their tracking steps, so I know exactly what that patient is waiting for. What we've also got is against predicted levels of activity. So as I was talking about, you know, if we'd have had a number of breaches, and so at QEQM we've had a number of breaches because we're not at 100% compliance, what we might ask the question is, okay, so you've had a couple of breaches, why is that? And we might get the immediate response back is that we've been busier, and actually we can immediately go back to them and say, actually we don't think you have been, because we think you're 8% less busier than we thought you were going to be. And I'm sure if there's time permitted, we can talk about the way in which we predict A&E activity. What clinicians might then come back to is say, actually, it's not busier than we thought, but actually the patients are sicker than we thought. And what we've done is we've actually created a case mix score, and that's based on the age of the patient, the gender of the patient, the time of the day of the week, and the presenting condition. So that if we know a 35-year-old male turns up on a Tuesday morning at 11 o'clock, with abdomen problems, we know that on average, based on historical activity, it's going to take about 3.5 hours in order to get that patient out of A&E. So we add all that time up, and we give a casement score for the whole department. We've also, the natural progression after the live A&E was doing one for the live inpatients report. So once again, incredibly visual. It tells me some very, very key statistics around what's happening in our departments and in our hospitals. So at Canterbury, for example, I know how many patients we've got in our beds. I know how many outliers we've got. I know what the split between emergency and elective patients. I know the split between divisions. And then I can also do the predicted levels of admissions and discharges today. So from midnight that night to 12:48, on our live reports, we always say when it was last refreshed, we have admitted 39 patients. We think we're going to admit 77 throughout the whole 24-hour period. And so between 12:48 and midnight, we're going to admit 38 more patients. The question then is, have you got 38 beds? If you haven't, what are you going to do about it? And so the divisions and the operational team have really engaged with us around this report to kind of say, okay, well, we think that's real, we don't think that's real, right, okay, what can we do in order to increase our number of admissions, what can we do to decrease our number of avoidable admissions, and so on and so forth. And what you've got is, on both the A&E and the inpatients, you've both got a very graphical view, and then you've both got a very data-rich view. And so if I click through into the patient level information, unsurprisingly, this is very, very data heavy. So it tells me who the patient is, and I've scrambled the surnames using the function in Qlik, when the patient was admitted, whether they've got an EDD and whether that was passed, an EDD is estimated date of discharge, what division, what specialty they're under, what ward they're on, and what consultant they're on. And the interesting thing is that as we've had these different products, like I was saying, we've had a real engagement with operational and clinical staff, and we've had more and more people come to us to kind of say, and can we flag up this, and can we flag up that? And one of our key things that we've established over the past 6 months is push alerting for patients with learning disabilities, dementia, and oncology. So that if a patient who is on our special register, on our PAS system, as having dementia, as soon as that patient turns up in A&E, a push alert goes out to that team, that specialist team, to notify them to come down to A&E, because the real key thing is around taking big data and how do you make the patient outcome better, both the patient and for the staff as well. So actually what we have seen is that we've seen there's been a demonstrable difference to the patient outcome the quicker the specialist team comes down and sees the patient. What we've recently done as well is we've created an activity planning schedule. Now, as many organisations will be coming up to the process about looking at activity planning for next year. And we had a very large Excel file last year and the year before around that. And what we found was that it was quite clunky to use, and so Rich and his team have developed a new business planning tool which enables us to have a look at both the in-month position, the predicted month position, and also the next year as well. And so what we're able to do is be able to select the division, the specialty, the different types of points of deliveries, the groups, whether it's a CCG contract or a specialist commissioning group contract, enable us to kind of say, right, sit down with our general managers and say, well, this is what we think is going to happen to do with A&E or outpatients, and then take it forward from there. So the activity planning schedule then enables us to have a look back at historic activity, being the black line, the current year activity being the black line, and then also the maroon line, which shows you what the plan is. So, for example, for the whole of the organisation, what we can then do is we can say, right, okay, so we expected it to be here, it was actually down here, do we think it's going to continue? And the good aspect around this is it enables us to have not only a good grasp of what's happening in the current year, but also what's going to happen over the next 2 years as well. So we've immediately got a plan for the next 2 years. And you can make good adjustments to it. The real innovative thing that Rich has just worked on is using the Qlik product is enabled to write back to a database, and I'm sure Rich can elaborate on this later, is being able to write back to a database if you want to make any amendments in the product. The metric view is a very real key one for us as well, because we've moved away from, we had the balanced scorecard, and the balanced scorecard is now developed into the metric viewer. So now you've got much more detailed metrics, and basically what you can do is the end user can actually create their own report based on different metrics. So if you want to, for example, have a look at the HSMR, and we're flagging up as red because our HSMR nationally is very, very low, you could then filter it down to specialty level very quickly, and then you can bookmark that so that every time you keep coming back to a specialty report. So if I was a trauma and orthopedic consultant, I could just click on trauma and orthopedics, have it by consultant, and then every time I went back into that report, it would tailor it for that specification. So that's the end of our presentation. What I'm just going to do now is I'm just going to come off the presentation, and I'm going to go on to have a look at the questions that have been coming in so far. So the first question we have is, how many apps do you develop per quarter? So Rich, do you want to say about the amount of apps that we've currently got?
Yeah, well, we've got about 10 major apps at the moment, but we do a lot of development on improving those apps and releasing different versions. So it depends really on whether you're talking about just improving apps or brand new apps, but we've got kind of a set of apps already in our catalogue, so we just really improve those rather than create new ones.
Okay. Claire, do you want to, or Adam, do you want to say anything before we just go through the other questions?
Yes, and no, did you hear me, Chris?
I didn't, I'm afraid, no.
Okay, so basically, no, if you want to answer the questions, that would be perfect.
Okay, that's fine. So we'll just run through these, and if anybody else has got any questions, please feel free if you send them over to Claire, and she can and she's been sending them over. So we'll just walk our way down this. So what is the mapping tool called, and how much is it?
We use the open source mapping tool from OpenStreetMap to get all of the mapping files that we use to plot the data on, but there's a bit of complicated work within Qlik to kind of put those points on the map, etc. I imagine that we can discuss something outside of this about how much things cost, etc.
Yeah, I'll go down one question and I'll come back to the question because that one kind of links in. So the question is EKBI an independent company outside of the NHS? Simply no, it's not. The reason why EKBI was set up is that, like every trust in the country, we've got to save money. And whereas in the past it's tended to be kind of specialties have been asked to save money, this year the information department has also been asked, as well as every department in the company. So we've got to find 7% of savings. We don't have many contracts, and so therefore that would involve us getting rid of staff. And actually what we found was that we didn't want to get rid of staff. If anything, we wanted to actually get more staff so that we could do more interesting ideas such as some of the products that we've created in Qlik. So EKBI is part of the NHS. We do work for other trusts, both hospital trusts, community services, mental health trusts. We're working with primary care colleagues as well. So we have written proposals, and at the moment we do everything by ourselves. So we will write the proposals, and we will come out and engage with different people. So if anybody does want to get into contact, there's our contact details on the screen. So please feel free to drop us an email, go on our website, or go on our Twitter feed as well. So thank you for that question. Next question is, what other predictive work have you been involved in apart from A&E? So at the moment, the only other work that I've been involved in is around the A&E admissions, and also looking at the profile of A&E patients, but also to do with inpatients as well. So one of the products that we've got, and I'll only briefly talk about this because it's not in QlikView yet, is the capacity modeler. And so basically what this does in a nutshell is it looks at the number of admissions we've had, and it forecasts that going forward for the next 18 months. It also predicts length of stay of patients as well. and because we've predicted length of stay and inpatients, we can predict the amount of beds or capacity that we're going to need for the next 18 months, changing by month. So that what we can then do is we can then post different scenarios to this. We've got 5 inbuilt scenarios, and we can see whether we should focus on ambulatory care patients or long-stay patients or patients over 75 or short-stay patients, and basically enable us to create great efficiencies within our current bed base so that we can have a look at financial savings as well as improving patient care. Next question is, how is the modelling for the casements prediction of A&E cases done? Okay, so yeah, as I briefly explained, what it basically does is it looks at 3 years worth of historical data, big data if you will, and it looks at 5 variables for patients who come into our A&E departments, and it looks at the age of patients, and that's grouped into 5-year age categories. It looks at the time of day by hour. It looks at the day of the week the patients come in. It looks at the gender of the patient, and it looks at the presenting condition of the patient. And so it basically says, if we just take each one of these by itself, it basically says, right, okay, so I'm a child between the ages of 0 and 5. Roughly, the average time that a patient spends in A&E for that category is 3 hours and 5 minutes. And it basically creates a score for each of those metrics, each of those 5 metrics, and then it says, right, okay, so this patient has got a score of X. And it basically adds up all of the scores in a department, divides that number by the total number in the department, and it gives us our score. And then we've put a RAG rating around those overall scores. So I hope that answered that question, but if not, please feel free to get back to me on that one. The next one is a great one. What methods have you used to get clinical buy-in? Money? No, we haven't, or chocolate or something like that. I think the biggest one for us, as I've kind of I almost skipped over it actually in our second slide, and that's basically that when you only have a small information department, you can't get out from behind your desk. You're inundated with requests of doing both ad hoc requests, but then also statutory returns and the quote-unquote boring stuff that you have to do. The real big change for us is that we have got out from behind our desk and we've gone out to meet people. So we haven't asked clinicians to come and meet us. We said, I'll tell you what, I'm going to come and spend a day and I'm going to come and shadow you to understand what it is you do, how you do it, what gets recorded, how can I get access to that data, and so on and so forth. So I think the big thing for us is because we've made the effort to go out and actually spend time with them, they've actually then seen the benefit of what we can provide. So when people say to us, particularly around the push alerting for the long-term conditions patients, the clinicians around that have been a real big advocate for the work that we've done. And so they actually go out and speak to more people. And so although 6 months ago we only had learning disabilities, Parkinson's, learning disabilities, dementia, and the other one, which has gone completely off the top of my head. Now we've got about a dozen or so different conditions that people have come to us and say, can we look at patients with a high risk of a fall or a high risk of X, Y, and Z? And that's been a real big thing for us. So I would say the thing is, it's about getting away from your desks and actually going out and meeting people rather than having to come to you. So next question is the product able to support the integration of electronic patient records with genomic and diagnostic imaging data? Yeah, that's a challenge one. I think I'll pass over to Richard for that.
Yeah, we do incorporate our electronic patient record as it is at the moment. Our electronic patient record, the way we only are able to look at some letters that are produced through the system, but they can be clicked using a web link and it takes you straight to that letter. But I suppose it's completely dependent on the application and how you're authenticated between Qlik and other applications on your system. But I think some investigation, you probably will be able to do something.
Okay, thanks, Richard. Okay, so that's we've gone through all of the questions that have been posed so far. So unless there's anything else, I'll hand back from Claire. But just to thank Qlik and the people that have registered to be on this event today. If you have got any questions or you'd like any information about this, please feel free to go on Twitter, email me, or go on our website. We've just had one more question. Where do we send the push alerts, from Qlik or some other system?
We send them through Qlik itself. So you can do it from the alerting system within Qlik, and we do it through the emails. We're currently looking at pushing out more things through text messaging we currently do, but we're limited by NHS.net mail with that. But yeah, everything goes through email alerts at the moment.
Great. Well, thanks very much.
Okay. Well,
I'll just hand you back.
No, it was very interesting to hear. I do actually have a question myself, which I think might be more in Rich's domain. I was just interested to know, do you have sort of specific criteria that you're looking to meet before you decide to develop an application to sort of solve or improve that problem or solution?
Yeah, we do actually. We have a development prioritisation group where anyone can basically come to the group throughout the trust, but although it's predominantly information staff, with an idea. They have to fill out a one-page document to say what it is, who it will benefit, what money it will save, etc., etc. Then that's viewed by a panel, and this really helps the process because it stops people just wanting things for themselves or a very small group of people, and so they have to prove how it's going to benefit the trust and how it's going to end up benefiting the patient at the end of things.
Okay. Well, no, just thank you very much for taking the time, Richard and Chris, to run everyone through what you're doing down there at East Kent with the Beautiful Data initiative. And I guess from our side of things, we'll be hosting the Visualise Your World tour in London on the 21st and the 22nd of October. If anybody would be interested to come along to see that, we can send out invitations in the sort of future. If you do have any further questions around what we've discussed today, and from what I can see, there's quite a lot of information there of best practice and how to go about sort of improving the way that things are done within the acute trust, then send them through to rachel.bell@qlik.com, and what we'll do is we'll either forward them on to Richard and Chris to answer if they're more around what has been presented today, and if they're of a more technical nature, it may be someone at Qlik. So I'd just like to thank everybody for taking the time to attend and listen to this, and I hope you found it as interesting and useful as I have.
Thanks very much.
Cheers.
Thank you. Thank you very much.